2 minutes, but it's almost 2, sorry. And I mean, respectful to you that are here. If not, we miss most of the time. So we'll go back to guidelines. You had 2 units this morning, guidelines and diagnosis. Diagnosis, you had the practicum already. This is the workshop on guidelines. And I try to tell you how good guidelines are done, but not every guidelines is the same. So this is the main result of an experiment, of a research project done in UK now about 10 years ago, where they looked for all the guidelines on atrial fibrillation. And then they said, well, okay, let's take the next 100 patients that come to the atrial fibrillation anticoagulation clinic, and let's see if applying the guidelines, we will make a decision to treat or not to treat this patient. And depending on the guideline, there were some guidelines where all the 100 patients would have gone on anticoagulants, and another guidelines only 13, with everything in between. So they made the point that sometimes guidelines on the same topic, they get to different conclusions. And this is not what you want. Ideally, you would imagine that this is clinical practice. In different centers, you have a different proportion of patients that are put on treatment, and then after a guideline, you get the same proportion everywhere. Instead, it tells that guidelines may be very different. Why they are different? Ideally, you would not expect so much variability. All the guidelines were reporting to be evidence-based, and some did a systematic search, some had their expert on the panel, some considered cost, some considered other aspects. So the problem is in the please.
Excuse me, when you review a guidelines, what do you call it? Review a guidelines or a new guidelines? What do you give?
So when you review a guideline, you mean when you appraise a guideline, when you judge if it's good or bad?
So what do you call that?
You call it critical appraisal. Oh, no, so you mean what you call the activity or what you call the paper?
The paper.
Oh, the paper usually is called a critical appraisal of a guideline or critical appraisal of a set of guidelines. Usually there are tools like Agree2 or the Institute of Medicine tool, or there's another tool called Write. They are checklists, like the user guides of the literature for diagnosis, therapy, systematic review. So there are items you look at, and then you say good or not, and then you give a score to the guideline. You call that a critical appraisal paper. That is not really a systematic review. So you have to distinguish among literature 2 broad categories of paper: original research and secondary paper. Original research are trials, so randomized trial, cohort studies, case control studies, and they can be in therapy, diagnosis, prognosis. Those are studies done on patient and producing some evidence, original studies. Systematic reviews are still considered original studies because systematic reviews take all the studies in a field and they make a synthesis, a summary. So they still produce something new. The summary is not coming from studying patient, but is adding something on top of the studies. So both clinical trials, observational studies, studies on patient, and systematic review are called primary studies, primary research, original research. All the rest editorial, letters to the editor, commentaries, and critical appraisal papers are called secondary literature. A guideline is not original research. A guideline does not generate any new evidence. What a guideline does, take evidence from the primary studies and transform that evidence into recommendation. So the guideline per se is not primary evidence, is not primary study, is secondary. So it's in the knowledge translation part. It brings research result closer to the patient. A study assessing the quality of guidelines, again, is secondary research. It helps you saying, okay, among those 15, which one I pick? But it's not creating any new evidence. Is this answering your question? Okay. Now, these are the IOM standards for guidelines. And they say that guidelines should be transparent, should manage conflict of interest. So if we were to issue a recommendation in a specific field, we would go around the table and each one of us would say, I have worked for this pharma, or I work in breast cancer prevention. My partner holds stock from a company, and so on. We would disclose the conflicts of interest in a transparent way. The panel should represent everyone. So cancer screening prevention, the guidelines would likely have a gynecologist, oncologist, radiologist, patient representatives, palliative care expert, pain doctors, and so on. All those involved has to be involved in the process. There should be a systematic review and a clear description on how to go from the evidence to the recommendation, so what we covered this morning. A clear way of wording the recommendation. And then what you would like to see is that someone set all of these, the work was done before being released, the guideline has been put up somewhere for public comment. So we spend one day here, we have someone reviewing all the evidence, we see the summary of the evidence, we make the recommendation. Before adopting those recommendations, publishing, putting on a website, starting in practice, we would say, okay, we have done the job, the document is here, and we send it around to other experts in the field, again, to patient organization, policymaker, Ministry of Health, and we say what you think of this document. It is clear. We would not like people saying, oh, you should have recommended something different. No, we decide what to recommend. But were we successful in making clear statements? Is it clear why we made the statement? You may agree or disagree, but were we able to describe how we got to the conclusion? All of that should be what happened here? Okay, well, we might do without. This is gone. Anyways, all of this should happen in a commented way. So peer review of the document, not by reviewers like in a journal, but open review, open comment from the stakeholders. I think one was disconnected and two, the computer rebooted. So it's a complete disaster. Okay, so that's the landscape for the guideline development. Now, you have a clinical scenario that I might be able to put on screen again. Maybe someone of you has the clinical scenario and you can read it while I restart this thing.
My designated job.
Good. So.
Okay. background. In 1998, the British Medical Journal, or BMJ, published an article entitled Guidelines on Anticoagulant Treatment in Atrial Fibrillation in Great Britain. Variation in content and implications for treatment. Document 2 in the reading material. We will not critically appraise this article, but will review its findings briefly. It clearly illustrates one of the problems with clinical guidelines that you should understand. The authors applied 20 separate clinical guidelines for anticoagulation and atrial fibrillation to 100 patients with atrial fibrillation. They reported that the percent of patients for whom anticoagulation was recommended by the guidelines ranged from 13% to 100%. See the figure provided in the paper. This wide range in clinical advice, depending on the guideline, emphasizes the point that many guidelines may be developed non-systematically and may be based on an opinion rather than an evidence-based process. Most of the guidelines in the study were not developed using evidence-based methods. It is therefore important to know how to identify, using critical appraisals, which guidelines correctly reflect the evidence base in the medical literature. The problem of differing levels of prescriber in producing guidelines has led to efforts to standardize methods for guideline development. The GRADE working group, with the link provided, is a group that has addressed this issue, with particular attention given to 1. How to assess the quality of clinical research evidence, and 2. How to grade the strength of clinical practice recommendations. This effort also addresses the problem that clinicians face when each guideline for medical association creates their own grading system, such that B evidence in one guideline could refer to the same evidence as 3 double plus or 2(1)A in other guidelines. This tutorial reviews the components of critical appraisal for clinical guidelines.
Okay, good. Thank you. So that's the premise. And the way this tutorial is organized is that we start from a clinical case. This one here, a 36-year-old female patient, followed for 3 years for obesity and hypertension, comes to you saying that she's pregnant, 3 weeks. And she wants to know if she should continue taking metoprolol for hypertension, and what are the risks of adverse outcomes for metoprolol for her and for the baby. And these are the clinical assessment, cardiac examination, and so on. Normal lab. And what's the PICO question for this case? So the population is pregnant. Yes.
Yeah, she is pregnant. She's pregnant.
Yep. Pregnant. So pregnant women with mild chronic hypertension. Treatment? Beta blocker. Compared to? No treatment or another antihypertensive. Yeah. Risk of?
Complication.
Which kind of complication?
Preeclampsia, preeclampsia, or hypertension associated with pregnancy.
Yeah, preeclampsia, eclampsia, death, growth retard, low birth weight, abortion, or any congenital defects. Okay. Now, in this case, instead of going to search for primary evidence, so studies or systematic review, we try to see if there's a guideline. So we go to the National Clearinghouse. This is a repository of guidelines cured by the Agency for Health-related Quality of Life in the States, and we search for hypertension and pregnancy. And we find 24 guidelines. So a situation similar to the one in atrial fibrillation, among which we select a few. The most recent, so we select one in UK, NICE guideline in 2010. There's a guideline of this Society of Obstetrics and Gynecology in Canada, 2008. And then there is also a US-based guideline in 2012. There is nothing more recent. And we select these three for them being the more recent and also being free access. We don't want to pay for a guideline. There are 24, and we think, well, hopefully one of those three will be okay. So we select those two. On the site you can compare guideline if you want, and you can check population, intervention, and so on in parallel. Now, yeah, here it tells the story. We select 2, and then a friend of ours tell that there's also one free from the from the AmeriGroup guideline that is there. Now, the way we work is we split in 2, so you on this side, them on those side. One of you take the Canadian guideline, and the other one take the NICE guideline. So you take the Canadian, you take the NICE, and you have a set of questions. Now, it's 2:10. We have to be out of here in 1 hour. So let's take half an hour for you to answer the question. You don't need to read the guideline. You just need to answer those questions based on your guideline. And then in half an hour, we compare those 2, and we also check the third document. The third document I don't need anyone to read because it's very short and it's very simple, so we will just check it while comparing the 2 others. While you work, I'm here, and if you have doubt, we can clear. 3, 2, 1, go. I might have the question for you. Okay. This is the form that you have to fill, right? You have a series of questions to answer. You can put the answer or the page where you find the answer. If I can give you an advice, you may start on different questions. So I want only one field. So if you write, they can answer question 1, question 2. When they are done, you do 3, 4, and so on. So you save time. Then we will have a discussion all together. The same is for you. If you do 1 question each and someone writes, you use better the time. Yeah. Half of your time. How is going? You are half of the question? Good. Excellent. This is your last chance of completing a tutorial on time, so do your best.
Yes, management and anti-hypertensive medication BP, below this recommendation. Initial
Oh.
Good evidence, one sufficient lead, one sufficient evidence.
I think we have to go back to check what you have did. Yeah, what you have done, sorry. And the third guideline, the AmeriGroup guideline, is really more of a practical document. It's a 12-page long document published in 2012, and you'll see that is sold as a guideline. It says guideline, but it lacks many of the characteristics. So not always the more recent is best. So the first section of question is about composition of authors and conflict of interest. Have you found the composition of the group?
Yes.
Okay, so it's multidisciplinary. You are doing the NICE. So the NICE is multidisciplinary?
Obstetrician and health worker and physician with members, patients,
Okay, so you would say that it's okay?
physician and midwives, obstetrician and obstetric physician.
You have named 3 times the physician and the midwife, I say, right?
Yeah, one obstetrician and obstetric physician.
Okay, that's fine. What about the Canadian one?
The Canadian was developed by obstetrician gynecologist and internist.
Okay,
But it was reviewed. In the review, there was also anesthesiologist and perinatal expert. I don't know if that includes pediatrician, but that's only the review, not the development.
okay.
But not cases of patients.
There were patient, were there patient?
No.
No. In yours, there were patient?
Yeah, patient and
There were patient representative. Okay. So they tried to do something. There's nothing in the AmeriGroup, they say nothing about who wrote the guideline. The second question is about conflict of interest or bias. Is there any statement about conflict of interest in the NICE one?
yes.
Okay, so you found the statement. What did he say?
It is in the appendix in page 221.
Wow. And it says that they declared their conflict.
Yes.
Okay, good. What about the Canadian?
We didn't.
They did not clearly state there was that conflict of interest. There was no conflict. They did not state that. They stated that they received an unrestricted grant
Yeah?
from British Columbia, and that one of the institutes paid for the ticket for one of them.
Okay, so that's the funding of the guideline. But
But it was not stated clearly. That
Okay.
conflict of interest.
Okay. I think there is an appendix, like in the NICE case. I think there's an appendix B where,
It's not provided.
yeah, I think it's not provided. I'm just telling you. There's an appendix B where they actually put all the conflict of interest statement that the panel members signed, but it's not provided. So your answer is right. They did, but it's not in what you have. Okay, again, nothing on conflict of interest for the AmeriGroup. Now, my question to you is, as practicing clinician, when you use a guideline, do you check the composition of the group and conflict of interest or not?
Yeah.
Or you just go to the recommendation, look at what it says, and that's it?
No, I have to check.
No, I know that you have to. And what I'm asking is, do you do? No, you don't. Yeah. And I would say that I don't usually. I do in the guidelines I use for my specialty. So for bleeding and thrombosis, I check because that's what I use every day. But if I'm seeing a patient that I'm usually not saying, what I usually do, I trust the institution. So I go to guideline on the clearinghouse, and when you search, you can select those using a defined methodology, and that's what I do. But ideally, it would be important to check, because in this case it's there, in one is not. Okay. The second group of question is about validity. So validity is a judgment call. First is when was published. Yours was published in
August 2010.
2008, 10.
Yeah.
Oh, nice 2010. Instead,
2007.
March 2008.
2008, 2010, reviewed in 2011. So would you consider a guideline yours is about 8 years old and yours is 3 years old, would it be okay? What do you think? There's no golden rule. It depends on the disease. So this is treatment of hypertension in pregnancy, and the drug in question is metoprolol. When was metoprolol put on the market? Yeah, you were not born, and metoprolol was there already. So do you expect any new study? No. So very likely that's okay. Both are okay. Second question is the method documented? Do they say which method they used?
Yes.
Yes. So there are pages where they describe the method. What about NICE? Yes.
Yeah, table 2.
There's a table where they say the steps they follow. Okay. For the Ameri group, there's no method described. It says more or less nothing. What about the literature search? The following question, number 5. Is the search strategy reported?
Yes.
Yes.
They searched Medline with keywords, and each group was responsible for that keyword, and they reported back.
Okay, so sounds a quite structured process. What about NICE?
Yes.
Yes. And I think, if I recall correctly, in the NICE one, there is a full description of the search strategy. Is in an appendix again. Yeah, a table, and then there is a full appendix of many pages. So in both cases, I would be happy. Again, for this one, there is nothing. Yeah, so yes, there's a separate document. There's an appendix reporting all the strategy. There's something in the table and a full attached document. What about the quality of evidence assessment and grading the strength of recommendation? Do they specify the quality assessment, the risk of bias assessment, and do they say what the options are for the recommendation? Strong, weak, conditional? Is that described? So when you read the recommendation, if you don't understand, you can go somewhere and check what the meaning is. Okay. Not all the time that's in the guideline. For some guidelines, they say our method has been described somewhere else. So you have to go and pull another paper. It's a bit unpleasant, but you can do it. But in this case, in both cases, you have found where the method is described. Very good. There's nothing such in the Ameri group. That's all for validity, right? Method search. How many references? Have you checked how many references? 300, and in your case?
More than
I think it was 277. Yeah.
397.
397 in NICE were 277. So they searched, they found quite a bit of literature. Then number 7, I think, still in the same domain, is was there an external review? Yes. Do they say what they did in response to the external review? No. That's pretty typical. The NICE one, I think, published the comments, right? Have you find anything? NICE usually publish the comments, and there is also a brief response.
Yeah, they did the systemic review at the 3 levels. Levels of evidence for studies.
Do they say who did the review, the external review?
They say the resulting document was reviewed by guidelines and perinatal committees of SOGC, the British Columbia Perinatal Health Program, and the obstetric section of the Anesthesiologist Society.
Okay, so that seems reasonable. NICE, I don't know if you found it, but NICE has a standard way of doing. When they do guidelines, they put them on their website. They send an email around to all general physicians in UK, and to selected patient organizations. So I would imagine that they have done the same for this guideline here.
Just mention hierarchical system described above, and that's it.
What this says that day?
Hierarchical system was used.
A hierarchical system?
What is it? I'm not sure what it is.
I don't have any note on that. It says that is at page 45. I don't know if you have access to page 45. Usually it's very standard. They say that they have put it on the website and that's what happened. But for sure they did it. Have you answered question 8? So are the recommendations clear? Yeah, so you have read some and seems that is understandable. Okay, good. And are they clinically relevant? So do they tell you things that you can directly do? Do this, do that? Yeah, okay. Number 9, for this recommendation, there is a statement on the strength of the recommendation.
It's not major or minor, but they'll tell you 2A, and you have to look up 2A, so is it reliable or not?
Okay, so there is a ranking anyways.
Yeah.
Okay, so you can distinguish what is strong and what is weak. Good. For yours?
Yeah, they mentioned one by one. Like recommended to use this medication to follow.
Yeah, but can you tell which one is strong, which one is weak? No. Okay. Good. I mean, it's bad, but it's good that you picked it, because that's one defect of that. There is a place, there's a table where they put the level of evidence, but the recommendation, they are all the same. We recommend this, we recommend that, but there is no strength, there is no grading. So in this perspective, the Canadian one is better than NICE. Amerigroup, there's nothing at all. Do they make a plan for updating?
Yes.
Yes.
They will update after 3 years. After 2 years.
So now, we'll see next year if they have done it. Because in 2011, so it's gone. In 2011 they would have updated.
2014 then, so it should be the second update now.
Right. At this point, we are not sure if NICE has not done the update or FAD has not updated the document. So we'll need to ask, to suggest, because maybe there is an updated, just maybe it's not in the package of this exercise. But ideally, if a guideline says we plan to update in 2 years, we said before, and I agree with the colleague, well, we don't expect anything new. So I trust the guideline done in 2013, in 2011. On the other hand, if they had said we will update in 2 years, maybe they were expecting something to happen. So it's not nice. It's not. I would not like to have someone saying I will update in 2 years and then not doing it. Even if there is nothing, costs very little to say in 2013 we have checked the literature, nothing new, this continues to be valid. Take half an hour, you add a statement, and you confirm that the guideline is still up to date. Okay, let's move to domain C. Applicability to our patient. Number 11, does the guideline clearly describe the target population to which the recommendation apply? Yes. And does it apply to our patient?
Yes.
Okay.
To generalize, can we? That's the debate we have.
Well, there's no right or wrong. What do you think?
Yes.
Because patient is pregnant and hypertensive.
Our patient, the Canadian guideline is non-severe hypertension, and there's a clear that non-severe hypertension, this is the medication, blah, 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 blah.
So you would feel comfortable using this guideline for that patient. What about the nice one? Yeah.
They mentioned patient at risk
or chronic hypertensive.
and
Okay.
also are hypertensive, pregnant hypertensive during pregnancy, how to manage it. And also proteinuria patient.
Or at risk of
Or at risk of developing. Okay. Do they identify a single population for all the recommendation, or each of the recommendation is for a different population?
There was a separate recommendation for each.
For at-risk patients,
Okay, so you have different recommendation for different population. The population is included in the recommendation.
Yeah, three parts.
Okay.
Non-severe.
In yours not?
No, severe and non-severe hypertension.
Severe and non-severe. Okay. That's is a pretty common problem with guidelines. They define a general population and then they give recommendation, and for some of the recommendation they say for high risk patient, for some they say nothing, and then it might be confusing if to whom those with no population specified apply. Possibly to everyone, but it's always good to have the recommendation as the answer to a PICO question. The PICO question has always a population, so ideally you want to see the population in the recommendation. Okay, this can be improved for these two. Does the guideline clearly address my clinical question?
Yes.
Yes, so was good to read. And in this case, it's funny because this is the only thing that this guideline has. It answers the question. And it answers the question pretty right. It's not different what they recommend. Very likely what they did, they read other guidelines and they took the recommendation here and they made a much nicer, shorter, clearer document. So it's not necessarily bad. Just they should have had a sentence saying where they took the recommendation, because what they recommend is not that different indeed. Were all the important outcome considered? Yes. So you think that if you enter in a conversation with this patient and she asked already what will happen to me, what will happen to the baby, all those aspects are covered.
I mentioned two outcomes, maternal and fetal. And
So the two classes of outcome?
Yeah,
And-
and I mentioned all the maternal complication and all the fetal.
Okay, so they are all taken into account in issuing the recommendation. Is that true for the Canadian as well?
It's not so clearly stated. It says, for example, if we take her as the question, as the patient, it says at 1 year no fetal, at 18 months no evidence so far that there is any regarding her medication, the beta blockers. But it's not like well defined. You have to look in different areas of the guideline.
So it is covered, but it could have been made clearer and easier to use. Okay. Number 14, do they consider cost? No. In your case, do. Yeah, UK people always do consider cost. So what did they say about cost?
They took it into consideration, but exactly.
What do you expect about cost? This is metoprolol. Cheap. So are you worried that they don't consider cost while they are looking for where it is? Are you worried?
No.
No.
Because the other drugs that they're comparing to methyl-dopa and labetalol, that's the 1A recommendation, are almost, they should be all the same. Even methyl-dopa should be even cheaper.
Yeah.
I
So
don't see the big difference.
really, you can fail the healthcare system that way. Good. NICE does any consideration about cost?
Yeah, yeah.
Yeah, but what they say? Is-
Effectiveness of using aspirin to prevent preeclampsia.
So they make some cost effectiveness consideration. You were reading for aspirin.
But it was fully explained in the appendix. But they did.
I think they do some, but I don't recall they do any for metoprolol. It's too cheap even for UK people.
It should cost more to research the cost effective.
Yes, yes, definitely. Okay. Are there recommendations that are relevant to local situation? So do you think that you would apply these in Kuwait as well? Or is there anything different that makes it non-applicable? Of course, you have metoprolol available, it's covered, you can use it in pregnancy. Okay, I think this was the last question. Let's see. Yes, so let's see where we are. We are 10 minutes early. Any comment? Anything that you think is good out of both the lecture this morning and this? I mean, first of all, do you use guidelines in your current practice? Yeah, you use guidelines. You have Kuwaiti guidelines.
In some diseases, in some hospitals, we have like
Local policies.
Local policies. The local policies are based on international guidelines and they are made local, or they are just created here locally? Do you know? Created here. And do they follow a process that somehow resemble or have something in common with this way of doing guidelines? Do they cover who does it? Is a multidisciplinary committee?
The only guideline I know so far that's used is in our antibiotic policy, and each hospital is evidence-based. That I know.
And it's done by the hospital?
It's by the microbiology department, a small booklet with each, for example, non-complicated soft tissue infection or diabetic foot. Start clindamycin with this at this dose. And it's usually very simple because I reviewed it with up-to-date and reviewed it with the NICE guidelines. It's almost the same.
Okay.
I don't recall honestly if it mentioned what the resources were, but I think they did use.
Okay, so it's more of a policy. You're right, where they have possibly looked at guidelines and then made
Based
something
on the
that is easier to. Yeah. You were referring to some other guidelines or guidance?
What I remember where I'm working in Jannah Hospital, so we have a community of consultants.
Yeah.
To do local guidelines and most common disease which we face.
Okay.
But it's not published yet, just except some of the diseases. But it's based on it's taken from the big guidelines or from the up-to-date or something.
Yeah, that's a very common way to go. For example, US guidelines, they have a lot of discussion about cost, insurance. Very likely here you don't need that. Like in Canada or in Italy, you should have full coverage, I guess, for medication.
Yeah.
Yeah?
Now
Or is reducing. Okay. So a good idea is to start from international guidelines and then to make them local and checking if they apply or if there is something different. But so you use guideline. In general, I would say that if what is recommended makes sense and confirms what you are doing, usually you may just take them at face value. When they tell you something that you are not expecting, or the antibiotic they recommend is not the one you would use, or is discrepant from up to date or for what you do, or a new paper comes up showing something that is different from the guideline, you might then want to check the quality of the guideline. Do you, please?
Yeah, because for example, we had the other day a debate, patient, we had a question, clinical, but we had a patient with a gastric cancer, operated. Should he be discharged on anticoagulation or not? And for how long? So in comparing three reasons, we've compared the NCCN with up-to-date with the ESMO, so European, American, and up-to-date was just a pooling.
Yeah.
They all came up with the same.
Okay.
I mean, roughly 28, some were 30, but 2 days difference.
It's acceptable. Okay. So that's a very. I mean, it might take a little time the first time, but then the second patient you know what to do because you have checked it before. So in doing something like he's describing, if you have a situation where you need, okay, let's go and see what guidelines and textbook tell. Should you go back to do this job after today? Do you think you feel better equipped to assess guidelines? So did you learn something?
Yeah.
Okay.
Because before guidelines are like holy and it's supposed to be when you feel that the guideline, this is, when you want to debate someone, the guideline says this and this, so you be quiet. But you've never assessed, because you feel that the guideline is at the top of the pyramid. It's the highest thing, so you wouldn't.
Is there, but you know, you can have a pyramid of golden bars, or you can have a pyramid of other material, and it's still a pyramid, but the smell is different. So you need to check quality also for guidelines. Good. 5-minute stretch, actually 10-minute stretch, and then the final lecture. And then you're gone. It's weekend, right? Starting this.
I'm on calls.
Oh, well, good for you. You are on call. Oh, well, that's what you pay for having been at the course. Then you take the weekend on call. Sorry for that. I'm flying, so more or less not fun. Okay.